Hey guys, we're going to pick right back up where we left off in class, all about classifying drugs. We talked about how you can classify drugs in a lot of different ways in class already. One way that you can classify drugs is using the Drug Enforcement Agency's schedule of drugs. And depending on the abuse potential of the drug and how useful it is in a medical situation, kind of determines where it falls on the schedule. So, for example, with no medical use and a really high potential for abuse, marijuana, ecstasy, peyote, LSD, heroin is considered a Schedule 1 drug, whereas cough syrup with, for example, codeine, like Robitussin, is considered a Schedule 5 drug because it has a low potential for abuse. Now, we've talked in class about the fact that marijuana and even LSD and certain other drugs are starting to become used for clinical settings, and we're going to talk about how that might affect how this drug is classified by the Drug Enforcement Agency. But as of right now, marijuana sits at a Schedule 1, the highest schedule level. So we're going to go over some commonly abused drugs. We've talked about opiates before, and so there's another lecture that has more specific information on that, and we're going to go into it in detail as well in this lecture. We're going to talk about stimulants, alcohol, and cannabis for the end of this lecture. So if you look at opiates, these are we do have endogenous opioid receptors, and these are, for example, endorphins. And these, but the external opiates are derived from opium, the opium poppy. So the opiates work as a depressant to the central nervous system and can produce things like stupor. It can impact how you experience pain, and it can also do things like give you a sense of euphoria. So one particular effect that opiates have is that they work as an analgesic, and so this relieves pain. They also, opiates also can be used as an anesthetic during surgery to reduce pain sensation awareness as well. They do have a high abuse for potential, but there is quite a bit of clinical value in several of the opiates, as you can imagine, for pain reduction. Now, one problem, though, is that we do become tolerant to the pain relieving aspect of opiates, and so we might see, for example, somebody working to increase their dose and increase the amount of opiates they take over a period of time because it no longer works. So opiates have also been used for things like sedation, like, for example, during surgery, and hypothermia as well. Now, if we look at the history behind opiates, back in 1889, Bayer actually had a cough suppressant that contained heroin, which is an opiate, and that's because opiates work really well as cough suppressants, and heroin worked to do that. And the issue, of course, is that it became illegal because it was very addictive. And many of the drugs that we see illegal now were available over the counter, some for children, to help relieve particular symptoms. And we'll get into even more of this later on. So some examples of some opiate receptor agonists would be like heroin, morphine, oxycodone, Demerol, codeine, and they work to bind to opiates, and they work as an agonist in those situations. And we see this euphoria and in sort of reaction to that. We also have medications that work as antagonists, meaning that they're blocking the opioid receptors, and naltrexone is an example of this. It helps with opioid and alcohol dependence. If you have a person, for example, who is abusing and addicted to opioids or alcohol, and they take naltrexone as a medication, the idea is that if they, for example, if they're an alcoholic and they consume a bunch of alcohol, they will actually be very physically ill. The medication naltrexone does work to make people feel really awful, and it's to discourage people from taking opioids and alcohol. Naloxone is also known as Narcan. And this is another opioid antagonist, and this works for overdoses. So if you are an emergency services worker and you go out on a call and a person is suspected of taking opioids and they are very obviously experiencing an overdose, if you administer Narcan, which is available in either injection form, kind of like an EpiPen, or if there's a particular version where you can actually have a spray up the nose. If you administer a dose or 2 doses, depending on how severe the overdose is, you can actually reverse it. So if you get to them in time, you can save a person's life by using naloxone to reverse that overdose. And what happens is it blocks off those receptors and doesn't allow any more binding to occur. And so it very quickly reverses the overdose and can, save someone's life. There's a lot of ethical debate about this, but I just want you to kind of know the facts behind how Narcan works, not necessarily the sort of philosophical debate on, saving people from overdoses. Now, so that's opiates in a nutshell. When it comes to stimulants, these are going to increase the activity of the nervous system. Some of them work by increasing excitatory signal. So they work by stimulating something like acetylcholine, whereas others work to block inhibition. And still working as a stimulant. So an example of this would be caffeine as a stimulant, works by blocking adenosine. And adenosine makes us feel sleepy. And so if caffeine is blocking adenosine, then that's working as a stimulant to block off the chemicals that make us tired. Now, there are several different types of stimulants. The ones that we're going to focus on today are nicotine, which is what we get from tobacco and smoking, cigarettes, for example. We're going to talk about amphetamine and amphetamine-related drugs, and also synthetic cathinones. An example of this would be bath salts as the sort of street name for that. What's really important to consider is even though it increases the activity of the nervous system, even though stimulants do this, an example of something that really works to amp up the nervous system is amphetamines. So even though amphetamines really do increase a person's productivity, it really does not increase the quality of their work. So it increases their motivation, but not their actual cognitive ability. So if a person on amphetamines might feel amped up, they may feel more productive and are actually producing more work, but it actually isn't any better quality than if they weren't on the stimulant. So another example specifically of a stimulant is nicotine. That is a component of tobacco, and we see also with vaping, but we're not going to get too much into vaping, honestly, because there's not a whole lot of research yet on it. We don't know the dangers of vaping quite yet. We know that there are some danger in the chemicals that are in the vaping liquids, but the nicotine itself works the same as it does if you were to smoke a cigarette. For a person who's smoking for the first time, they're going to, once they smoke their first cigarette, they will very likely experience nausea. They might throw up. They're probably going to cough because of the irritation to the throat and to the lungs. They're probably going to sweat and feel really jittery. For people who smoke regularly and have regular nicotine in their system, they will probably feel more relaxed after smoking. A lot of people like to smoke after meals. They smoke if they feel anxious, and they also feel an increased alertness. And so that's the effect that you get after you have consumed enough nicotine or smoked enough cigarettes to be used to the effects. Now, each of these, and one final thing about nicotine is that it works by activating the nicotinic acetylcholinergic receptors. And so it opens the ion channel to allow more acetylcholine to come in. And so if you smoke too much, you can actually feel really jittery, and that can, kind of affect your motor, some motor factors as well. One thing that we're going to cover for each of these is looking at how the dopamine release looks from drug to drug. And as you can see here, we have the closed circles. This is sort of the peak here of the dopamine release. The closed circles represent the dopamine release in the nucleus accumbens shell, and these open circles represent the dopamine release in the VTA, or the ventral tegmental area. And as you can see, there is a rush of dopamine, which corresponds, of course, to the feelings of pleasure that one experiences after smoking a cigarette. Now, amphetamines are also something that we're going to talk about here. Synthetic psychostimulants, for example, methamphetamine. We're talking about different kinds of amphetamines that all produce generally the same effect. We're not going to talk about any medications, for example, for ADHD or anything specifically. We're just going to talk about sort of amphetamines in general. What they do is they increase alertness. You experience a sort of euphoria, especially depending on the dose. And because it's a stimulant, it promotes sustained effort without having to feel the need to rest or feel the need to sleep. You feel like go, go, go. And this is where it's really important to consider that it does increase your productivity, but not necessarily the quality of your work. With amphetamines, tolerance to the euphoria and the alertness do develop really quickly. And if you use amphetamines for a period of time, especially at high doses, it actually starts to look a lot like paranoid schizophrenia. And in fact, for example, if you're using methamphetamine, which is missing any here, if you're using methamphetamine, which is a derivative of amphetamine, and you go to a doctor and you're experiencing this sort of paranoia and psychosis, it's actually near impossible to tell the difference between a psychotic break because of paranoid schizophrenia and methamphetamine use, or amphetamine use. And so the only real way to get at this is to ask the person if they're actually using a particular medication, and if they're using any kind of derivative of amphetamine, chances are they actually don't have paranoid schizophrenia. They're just experiencing this psychosis. So you do have to be careful, of course, when treating someone, to make sure that what they're experiencing is an effect of a drug, not necessarily a disorder that they are diagnosed with. Another derivative of amphetamine is ecstasy, or MDMA. Now, again, this is a this graph here is sort of an explanation of the frontal white matter that people have and how it changes over time. So this line here is the control, and you would expect that the frontal white matter doesn't change for a person who's not using amphetamines. But it turns out that over time, we're seeing that the amount of white matter is actually decreasing in users. And so you have to be really careful, because this kind of brain damage, we're actually losing tissue. Your tissue's atrophying. You need to be careful, because this might actually be irreversible damage. Once you lose this tissue, especially at a certain point, that brain damage is going to stick around. We know that that amphetamines also act on the autonomic nervous system in that it will it sort of stimulate all sorts of different systems, and one in particular, the autonomic nervous system leads to things like your blood pressure raises, you might experience tremors or shaking, you might feel dizzy, and you might be sweating excessively, you might feel nauseated. And so what's interesting is that amphetamines also work on dopamine transporters, and it runs them in reverse. And so by doing this, it actually increases very sharply the amount of dopamine in your system. So this example here is methamphetamine, and this is in just a very short period of time. Within 30 minutes, you're seeing a very sharp increase in dopamine. And remember that dopamine is related to the reward sensation and pleasure sensation that one experiences with drug use. So this can be really dangerous. And this is specifically dopamine release in the nucleus accumbens. Another stimulant is synthetic cathinones or bath salts. These can be extremely dangerous, and what's really concerning is that people who were taking bath salts, and this was actually much more popular about a decade ago, and so people were taking bath salts and doing some really off the wall things. And what it does is it's almost an amphetamine-like stimulant, and it does give effects of euphoria. It makes people more sociable and increases their sex drive, but it also gives you feelings of paranoia, agitation, and hallucinations. And people were actually doing things like almost turning into zombies and biting other people, and people on bath salts would take all their clothes off and run around and do some really disturbing things because they were experiencing hallucinations, and it made them very paranoid, and they were obviously very agitated. And so this is a really dangerous drug, especially because not only is the drug itself dangerous, but people were buying some really crazy synthetics that had a lot of additional chemicals in it, and those combinations were very, very dangerous. Now, another drug that we're going to cover is alcohol. And so alcohol is a depressant, and it works in a biphasic action. So it works as a stimulant in stimulating certain systems, but it also works as a depressant on your central nervous system. And it can stimulate sort of different systems. So sometimes people will drink alcohol and they might feel a little jittery, but it mostly works as a depressant on your central nervous system. And so at low doses, you see things like decreased inhibition, where the person might be making poor decisions because normally they wouldn't go and talk to somebody, or they wouldn't put themselves in a situation, but because of this decreased inhibition, they're more likely to talk to somebody or be talkative, because it lowers that filter and removes the filter that you normally wouldn't do those things. It also gives a mild feeling of euphoria, and it helps relieve anxiety. Now, as you increase the dose, you're going to see more impaired cognition, impaired perception, impaired ability to make decisions, and also impaired motor skills, where the person is going to have difficulty even standing. They may be stumbling around. And as you increase the dose, for example, you're getting to blood alcohol levels of like 0.4. Now we're talking about very deadly doses of alcohol poisoning. And because it acts as a depressant, if it depresses your respiratory system, then that means it's going to end up, you're going to stop breathing. And so you have to be really careful with alcohol. It works on two different receptor types. It is indirectly an agonist at the GABA A receptor sites, and then it's an indirect antagonist at the NMDA receptors. We know that chronic use does cause long-term brain damage, and in some cases this is irreversible. So we see damage at the level of the cerebellum, the hippocampus, superior frontal cortex. We see that some of this damage actually ends up in atrophy, meaning that these cells are dying. But if you're able to abstain soon enough and withdraw from alcohol use, the idea is that if you do it early enough, that you're going to essentially be able to reverse some of this damage. But if you're, using for 40 years and you're binge drinking on a regular basis, we're looking at really, really serious damage. For example, you can develop Korsakoff syndrome, which usually doesn't necessarily occur from the alcohol itself, but from a poor diet. You're not eating, you're just drinking alcohol. And so Korsakoff syndrome is kind of two types of amnesia. You experience the amnesia where you can't remember the past, and you also can't remember your present. And so what's happening is that you kind of don't know who you are, or you don't know what's going on. You can't make new memories, and you can't remember old memories. And so this can be a very, very, very awful condition. And so you have to be really careful about excessive use over time, especially. If you're using alcohol excessively, you do become tolerant, and you can, of course, develop some serious health conditions. But withdrawal from alcohol use, especially over a long period of time, we're talking about being really severe withdrawal symptoms. And so you would need to do so in a setting with, for example, rehabilitation setting, with access to doctors for very serious alcohol use. When it comes to brain damage, we can see here that this is a normal 43-year-old woman. This is an MRI of her brain, or his or her brain. And then here we have an alcoholic. And so if you look here, these are 43-year-old people. You can see the atrophy all right here. And so the brain actually just shrinks. It just looks like it's shrinking in these particular areas. And the brain is losing matter. There is a hereditary component to alcohol. There's some evidence that there is use of excessive alcohol use in different generations, and how even if you're adopted and raised by a different environment, you still have some risk of being addicted to alcohol. With twin studies, we do see, for example, with identical twins, that there's a higher rate of both twins being alcoholic. And so one thing that you have to really be careful of is that even 4 days worth of binge drinking can cause visible brain damage. And so one particular place that we see this damage is actually in the hippocampus. And we know that in the adult brain, as for right now, the only place where we know that we see neurogenesis or creation of new neurons is the hippocampus. And so if this is reducing the rate of neurogenesis, then you're stopping cells from forming, you're stopping new cells from being created. And so even a short-term use could really, be related to this particular damage. So binge drinking has been known to be very problematic. Fetal alcohol syndrome, or fetal alcohol spectrum disorder, which is kind of what we refer to it as now, is a spectrum. And so obviously if a woman is consuming alcohol excessively versus somebody who has only consumed it a little bit during her pregnancy, you might still see both children with particular symptoms of fetal alcohol spectrum disorder. But what happens is that the one who consumed alcohol at the vital times and consumed them more might have a child who's born with much more severe symptoms than a person who drank less. And so this is what fetal alcohol spectrum disorder is, what we see happen when a woman who's pregnant consumes alcohol, and that fetus in utero is exposed to the alcohol. What we see is a facial dysmorphology. There's a very specific pattern of the face where we see sort of wide set eyes. Here you can tell you actually see this flattened part of the lip. They have a long upper lip, and they don't have an indentation on their lip. Okay, this is kind of gone. This indentation is not there. It's a smooth upper lip. And you can see that they tend to have a small nose, and they have a narrow forehead, and you can kind of see this on some of these children here. There's a good description here. Now, when you take rat pups or mice pups, and then you put them and expose them to alcohol, here is a control, which is one that was not exposed to ethanol. Here is one that was. You actually see the same features. You see the narrow forehead, you see a small nose, so comparatively to that one, that long upper lip here compared to this right here with a nice dent there, you actually see the same facial dysmorphology in a rat pup that you see in a child. You also see that babies tend to be born smaller, they tend to have delayed growth, and you see some dysfunctions with the central nervous system. Now remember, this is a 100% avoidable condition, and the idea is if you just don't consume alcohol while pregnant, then you're not going to have a baby born with this condition. Even at very low doses where a person isn't really drinking a whole lot through their pregnancy, although we see that binge drinking is obviously can be very detrimental to a fetus. Even very low doses, we see some subtle cognitive effects where the child is delayed. And then here again are some of the specific associated features that we see in a child born with this condition. This is an example here of a brain of a 6-week-old baby. And so this is a healthy brain. And then here we have a 6-week-old baby who has fetal alcohol spectrum disorder. And so here you can absolutely see the difference in the brain, how the brain is shaped, as well as the tissue compared to, and how much smaller it is compared to a healthy brain. And so this right here demonstrates also how dangerous the condition is. And honestly, in some cases, babies are just, they don't even survive birth because the condition is so severe. Now, one thing to consider, and unfortunately with fetal alcohol syndrome or fetal alcohol spectrum disorder, we don't see the reduction in rates that you would expect to see with education. It's really difficult to educate people in the communities that we need educated the most. And so even though people understand and know that it's dangerous to drink during pregnancy, what we do find is that the rates really haven't reduced as much as we would like to have seen since like the 1970s. We're also much quicker and better at identifying fetal alcohol spectrum disorder than we were even decades ago. So, we see more cases probably because we're identifying it better, but also we're not seeing a reduction in cases with education. One thing that we have to consider is mixing your drugs, right? So if you are drinking an alcoholic beverage and then you mix that with an energy drink, for example, doing Red Bull and vodka, we're not sure how, that's going to affect you. What we do find is that it probably has a synergistic effect where the caffeine is amping you up, and in the energy drink, for example, the Red Bull or Monster drink, and then vodka, for example, as an alcohol, is going to still continue to intoxicate you. What's probably going to happen is the caffeine is going to impair your perception of intoxication, as in you don't feel like you're that drunk, but it actually does not impair or impact how intoxicated you are. So this is really dangerous, because if you are doing a stimulant and you're doing alcohol, what ends up happening is that you might say, oh, I feel great, I'm fine to drive, and in fact, you're not fine to drive. And in that case, you end up making a poor decision and going to maybe to drive, and you're really actually very much intoxicated. And so you have to be careful with that. Also, mixing things like marijuana and alcohol can be problematic, because if you are going to drink alcohol and you drink too much, you do have a mechanism in place to make you throw up, to make sure that alcohol comes out of your system. And so marijuana suppresses this mechanism, and so you might actually be more susceptible to alcohol poisoning, because if you pair this with marijuana, because you're not going to throw up like you normally would. So looking at the different cannabinoids, and for example, marijuana, the main ingredient is THC, or tetrahydrocannabinol. And there are over 80 other cannabinoids, and we have endogenous cannabinoids and plant-derived ones. And so we have receptors for both, and we are able to have the effect of marijuana because we have those receptors readily available. Now, we know that the endogenous cannabinoids do play a role in development and play a role in our ability to learn and do things like that. Now, if you look at the prevalence of cigarettes, now this ends about 2009 or so, maybe 2010. Coming right here to this edge. And so looking at the cigarette use, if you look at 2007, cigarette use and marijuana use in 12th grade students was pretty much on par with each other. And so the idea is that marijuana use has kind of changed a bit since the 1970s. It sort of peaked here in the late 70s. And then it had its lowest point in the early 90s, and then kind of moved its way up and sort of paralleled out with cigarettes. So cigarette use has gone down, marijuana use has gone up since the early 90s, and I don't have the rates on the most recent use of marijuana, but it's really difficult also to tell because, it in some states is illegal and it's more easily available. Not legal for minors, but more readily accessible. So low doses of marijuana, you see this kind of increased sense of well-being. You feel pretty good. Might feel a little bit restless. You might feel hungry, or they call them the munchies. You might experience hilarity, and you feel very carefree. It does alter sensory perceptions. You might kind of almost not necessarily have a hallucination, but you might feel different. And you might feel like something's on you or feel like a weight is lifted. In higher doses, we're seeing memory impairment just for short term, slurred speech in some cases in really high doses, and a difficulty, for example, in carrying out tasks that you might need to plan or make decisions. And of course, there haven't been any cases of people dying from marijuana use, but if you pair it with other drugs, or if you do use in high doses and you try to do something like drive a car, you could definitely be impaired. And again, looking at the dopamine release here, you can see there is a sharp release of dopamine in Nucleus accumbens within the first about 40 minutes, and this is an injection, not smoking. So the final thing that I really want to cover is this idea of what is marijuana? Should it be listed as a Schedule I drug? Schedule I drug says it's a high abusive potential, limited or no use for medical reasons. But what we find is there is a lot of clinical use for it. It helps to treat nausea, for example, if you have cancer and you're undergoing chemotherapy, that can affect your appetite and make you feel nauseated. And marijuana can help with those feelings. It's used to treat glaucoma. And if you have a severe epilepsy related disorder, for example, Dravet syndrome, where you're having hundreds of seizures, in a week, or dozens of seizures in a day, marijuana may actually cut that down, or CBD, or may cut that down considerably, to where you can actually have a functioning life. So I encourage you to watch these two videos talking about how marijuana can be used in the clinical setting and used to treat especially these epilepsy-related disorders. So the question is if it does work in a medical sense, in a clinical sense, why is it still a Schedule I drug? Well, one is that they've started some clinical trials and they've been able to do that, and there's limited number of clinical trials. But it's not enough yet to show the benefits of treatment outweigh the risks associated with the drug, and that's arguable what those risks are. And an issue that we're seeing also is this consistency in dosage application. To be considered a legitimate medicine, the substance must have a well-defined and measurable ingredients that are consistent from one unit, for example, pill or injection, from one unit to the next. And this allows the doctors to determine dose and frequency. And the problem is that we don't have enough clinical trials over the same usage to say that it actually does work. So that's one thing that we have to really consider. Although if it really comes down to brass tacks, I think one major issue, the reason why marijuana is a Schedule 1 drug is because it's political. And so we see that people, for example, might be in jail for use of marijuana, or having basically having access to marijuana, or carrying it with them. And if a person is now in jail because of the fact that they had some marijuana on their person, if you now say this isn't a Schedule 1 drug, what do we do with all those individuals who are now, in a situation where, what they did isn't illegal anymore, and do they come out of jail? And so I think it's a huge political issue of, how are we going to treat this, and what can we do? And I believe that we're, once we can figure out the politics behind it, that we'll probably see marijuana being removed as a Schedule 1 drug. But there have been a lot of attempts to do so, and all of those so far have been failed attempts. So there's always petitions out to remove it. So I encourage you all to email me if you have any questions, and hope that you enjoyed this lecture series. Hope you all have a great day.